What I want to do for the next, roughly 15 minutes is to, go really quick through a case and sort of use that to highlight what I think are some pertinent points in the realm of neurocritical care in the ED. And this is a case that I'm sure everyone here has seen many, many times over the course of their careers. Middle-aged guy, history of hypertension, comes to ED, severe headache, and focal neurologic symptoms. And as you're, looking at this patient's vitals and doing his exam, you think to yourself, this guy has a brain problem. And you're thinking, yeah, it could be a stroke, but of course, with the onset of headache, the severe headache and so on, you're thinking, well, this could be a head bleed. So appropriately, you go and send the patient for a stat head CT, and you get this, nasty looking intraparenchymal bleed, rim of edema, already starting to see sign of mass effect with effacement of the lateral ventricle, little hints of midline shift. And as the patient's being wheeled back to your department, you're thinking to yourself, maybe you're thinking to yourself, I am now, for the next couple hours, this patient's neurointensivist. And no pressure or anything, but the decisions you make over the course of the next 1 to 2 hours are going to have significant effects on this patient's short and long-term outcomes. So the decisions are important, and that's what we're going to talk about today. So here are our jobs as ER docs practicing neurocritical care in the ED. Really 3 things: limiting what we call primary brain injury, preventing and treating secondary brain injury, and then supporting all those other organs that are not the brain. What do I mean by primary brain injury? It's basically the thing that brought the patient to the ED in the first place, whether it be trauma, a hemorrhage, a stroke. And it can be, the important thing to remember is it can be a fixed event that happened and is done, or more importantly, it could be an event that continues evolving and getting worse as time goes on. So our job is to identify the brain injury, to treat it, and if it's something that's going to evolve, to limit it as much as possible. And then secondary brain injury is the brain injury that happens afterwards, subsequently. And it's either, again, because of progression of the primary problem, worsening bleeding, worsening edema, whatever it may be, or O2 supply-demand mismatch to the brain that can happen for a number of factors. And we're going to focus the rest of the talk on this secondary brain injury, because the bulk of our job in the ED when practicing neurocritical care is anticipating secondary brain injury, identifying it, and then managing it. All right. So back to our patient. I think the first thing you probably fixate on this patient is the blood pressure. So let's talk about blood pressure a little bit. Hypotension is bad. Hypertension can be bad because they both can affect cerebral blood flow, and cerebral blood flow is the thing that is going to affect this patient's overall outcome moving forward. So we know hypotension in general is always bad, but it's particularly bad in someone who already has brain injury. The result of hypotension is ischemia, and the injured brain is that much more prone to developing ischemia, especially when they develop hypotension. And there's been time and time again, correlation showed between single events of hypotension and poor outcomes in various types of brain injury. So our job is to avoid hypotension, and then if it happens, figure out why and to properly manage it. Hypertension, on the other hand, can also be a problem. And usually in the setting of brain injury, stroke, brain hemorrhage, that kind of thing, the significant contributor to hypertension is the presence of a hypersympathetic state. You get brain injury, and then the brain releases a bunch of catecholamines, and the organs respond appropriately, raising the blood pressure. The result, though, is what we call breakthrough, which can either be hemorrhage, and that can be hemorrhage that's already there and gets worse, or new hemorrhage that develops on top of whatever's already going on. Ischemic stroke becoming hemorrhagic stroke. And the other part of breakthrough is cerebral edema. So hypertension makes these things more likely and makes them worse if they're already there. So some CNS problems, like head bleeds, require targeted blood pressure control, while some, like ischemic stroke, do not. They more benefit from permissive hypertension, just sort of, not touching the blood pressure unless you're going to do something like giving lytics. But let's talk about blood pressure control specifically within the framework of intracranial hemorrhage. So like I said, blood pressure, the higher the blood pressure, the longer the elevated blood pressure lasts, the more likely you're going to bleed, and the more you're going to bleed, and the more likely it is you're going to form edema and progress into edema. The specific targets in blood pressure control are still unclear. There have been a lot of conflicting data, a lot of conflicting large studies that have come out over the past decade or so. And going along with that, the AHA, ASA guidelines and other pertinent guidelines have unfortunately not been super helpful. But I think in general, sort of based on my interpretation of the data that are out there, in the ED, we should target a systolic blood pressure of less than 160 to 180. I think that's probably a reasonable target, okay? The other thing to avoid and to look for is what's called blood pressure variability. So just as hypotension and hypertension are bad, fluctuations in blood pressure, especially within that first 24 hours after presentation, are also bad. So while we're treating the blood pressure, we want to make sure that we're not seeing wide swings in blood pressure up and down. So the bottom line when it comes to treating hypertension in intracerebral hemorrhage is that we want gradual, careful reduction in blood pressure. You're in no rush. Your goal is to get the blood pressure to that less than 160 to 180 goal within the first hour to two, okay? What you don't want to do is to bombard the patient with antihypertensives and drop the pressure aggressively, and you want to avoid, again, wide swings in blood pressure. And the other thing to remember as well is that you want to do what the admitting service is going to do. So if you keep the patient at 160 to 180 or under 160 in the ED, then they go up to the neuro ICU and they drop them again, further down, that's probably going to do a disservice to the patient. So interfacing very closely with neurosurgery, with the neurocritical care team upstairs is going to be critical to help you sort of decide on the overall blood pressure target. So how do we do it? The best agents to use to drop blood pressure in someone with the head bleed are things that are quick onset, short acting, with predictable dose response and kinetics. So in other words, easily titratable. You can use bolus agents, but I will say that the sicker the patient is, the worse the head bleed is, the worse the neurologic exam is, the higher the blood pressure is, the lower your threshold should be to just start at infusion and get that gradual controlled reduction in blood pressure. As far as agents that are used for bolus therapy, the two most commonly used agents in the ED being labetalol and hydralazine, I'll just say because of all the stuff that's in that red box, just avoid IV hydralazine, especially in this patient population. Unpredictable and has the potential to cause actually ischemia to the brain if you use it. So if you're going for a bolus agent, use labetalol, and it has that benefit of actually being a sympatholytic agent, and which may work well in someone who's already in a hypersympathetic state to help treat the blood pressure. Sometimes you'll see just a single dose of IV labetalol will bring the blood pressure gradually down in the range. Okay, but like I said, the sicker the patient, the worse the bleed, the worse the brain, just have a lower threshold to start an infusion. Probably the easiest med to reach for in the ED is nicardipine, just because it comes pre-mixed in most EDs. You just grab it off the shelf and you start it. It, again, is easily titratable and most of the time can get you to your blood pressure goal in the majority of patients, okay? The downside is generally going to be tachycardia. Labetalol is also an option. You can use it as an infusion agent, but typically it takes longer to get it to the bedside than nicardipine. And usually the issue with labetalol, especially if you're infusing it, is going to be bradycardia. So what I think is a reasonable approach to managing blood pressure, if you want to try a bolus agent, start low and slow with a small dose, maybe 5 to 10 milligrams of IV labetalol, every 10 minutes to gradually get the patient down. But like I said, the sicker the patient is, just reach for the nicardipine, start that infusion, get it going. If you're finding that the patient is refractory to nicardipine, then add labetalol to get the blood pressure down. And again, gradual reduction over the course of 1 to 2 hours. That's what you're going for. You're not in a race here. Okay, and then once you get them in that target, hold them in that target as stably as possible. Okay, of course, close blood pressure monitoring, frequent non-invasive pressures as you're titrating. And again, if it's refractory or they're having swings in blood pressure, just put the A-line in so you're getting good sort of beat-to-beat real-time blood pressure measurements as you're titrating that short-acting agent. Okay. So we get back to our patient. We just started the nicardipine an hour ago. The blood pressure was getting better. And you check back in, and now the patient's encephalopathic, drowsy, barely opening eyes, pupils are constricted, and then just in front of you, he vomits. And the blood pressure that was under control is now spiked up again. And you think to yourself, very briefly what to do, but then you go and you decide to intubate. And deciding when to intubate, especially with this crowd, is not rocket science. I will just say that in the patient with brain injury, who again is more prone to the effects of all of the issues you can get with respiratory failure, have a lower threshold to intubate. Because what you want to do in these patients, if you're intubating, you want it to be controlled, you want it to be non-emergent, and you want it to be smooth. So early, low threshold for intubation. Okay, and part of avoiding all of these things and avoiding the problems that you can get in patients with brain injury is careful drug selection. Between etomidate and ketamine, I think both are fine. Just remember the idea that these patients who have brain injury are in a hypersympathetic state. So if you take someone in a hypersympathetic state and you bolus them with any agent, even the ones that are cardiovascularly stable, like etomidate, you can drop the blood pressure. Conversely, if you take a patient who's already hypersympathetic and you give them a sympathomimetic agent like ketamine, it may cause more hypertension than you're used to in the average patient that you're giving ketamine to. So probably starting low in your dosing in this patient who's already probably encephalopathic to begin with, starting low doses and then adding on more if you need it is the way to go. Okay. Don't let anybody scare you with the ICP spike with ketamine. Yes, ketamine can cause a brief spike in your ICP, but that spike in ICP is also accompanied by an increase in your mean arterial pressure. So the cerebral blood flow is actually preserved. So don't worry about the whole ICP spike problem. Ketamine is just fine. As far as paralytics, the main difference between your depolarizing and non-depolarizing options is the duration of action. So just understand that if you give this patient rocuronium, they're going to be paralyzed for about an hour. And so for about that hour, you're going to have no neuro exam. So just sort of keep that in mind. And again, don't be afraid of the fasciculations. Yes, they happen. No, they're not clinically relevant, even in someone who already has high ICP. All right. So you take your patient, you use etomidate and sucks, and you intubate them. Then you think to yourself, why did this patient decompensate? Why did they get more encephalopathic? Why did they start vomiting? So in this patient, with that CAT scan, with that edema, with that effacement, the concern, of course, is intracranial hypertension. Compartment syndrome of the brain, the cranium is a rigid space, and inside that cranium is three big things: the brain tissue, the blood, and the CSF. And if the volume of one of those things goes up, like blood with hemorrhage or CSF with hydrocephalus, the ICP goes up. When the ICP goes up, something else has to be pushed out of the brain. Initially, blood flow is compromised and you get ischemia, but ultimately what will happen is brain volume is pushed out and you get herniation. Okay. So controlling ICP, the goal of controlling ICP is avoiding ischemia and avoiding herniation. It would be nice if, like upstairs, we had ICP monitors already in place to detect patients who have intracranial hypertension, but in the ED, you're going to have to rely on clinical findings. So just remember, any deterioration in neurologic status in someone who has a lesion that is prone to high ICP, like a head bleed, especially a head bleed with mass effect, that should be at the top of your differential, especially if accompanied by pupillar abnormalities, changes in hemodynamics, and of course, posturing, which may be a sign of impending herniation. So what do? We have a bunch of options available to us to lower ICP acutely. And again, the goal is to prevent ischemia and to prevent herniation. I'm going to talk about some of these temporizing measures, but just understand that the definitive therapy for compartment syndrome is decompression. So the definitive therapy for intracranial hypertension is decompression of the cranium. So calling neurosurgery and getting them to cut on the skull and relieve some pressure. So all of this stuff is done with the goal of getting the patient to this stuff. So head elevation is one of the simplest, useful things that we can do at the bedside to manage high ICP. It's probably more just to sort of maintain ICP levels rather than, something that's going to have a significant effect, but it's an easy thing you can do, raising the head of the bed 30, 45 degrees, keeping the head in neutral position, basically to enhance venous drainage and to reduce that venous congestion that you can get when the ICP goes up. Okay, but if you're talking potency, probably the most potent weapon that we have easily available at the bedside is osmotherapy. So with osmotherapy, what we're doing is we're given a drug to suck free water out of the brain and to dump it into the bloodstream. and thereby reducing that brain parenchymal volume and reducing the ICP, at least temporarily. Okay. Osmotherapy can be given either as an acute therapy to rescue someone who has a spike in ICP who may be impending herniation, and or after that to maintain their ICP at a certain level. So rescue therapy and maintenance therapy. And the two most common osmotic agents that we have at our disposal are mannitol and hypertonic saline. Hypertonic saline, as you know, comes in various concentrations, the most common being 3% and 23.4%. The main difference between hypertonic saline and mannitol is that they're both osmotic agents. They both dry out the brain, but mannitol results ultimately in a diuresis. So it draws that free water out of the brain, dumps into the bloodstream, and eventually that's dumped out of the kidney. Whereas hypertonic saline, at least temporarily, is a volume expander. So it does not have that diuretic effect that mannitol has, and it has a more sustained effect on ICP. Whereas mannitol, like hypertonic, is quick onset, the effects are transient. So, practice-wise, mannitol is generally used only for rescue therapy because of this, and because of the fact that repeat dosing can be harmful, whereas hypertonic saline can be used both for rescue therapy and maintenance therapy. Okay, just remember that hypertonic can be caustic if it extravasates, so make sure you're giving it through a good peripheral vein if you're doing a rescue therapy. Mannitol has that extra step of having to filter it, so that may delay its therapy. The main advantage of mannitol in some places is that it's quicker to get, whereas hypertonic in some places takes a bit longer to get. So it really just depends. But the bottom line, I would say, because early on for rescue therapy, efficacy-wise, they're both pretty much the same. So for rescue therapy, grab the agent that you can get the quickest. If it's mannitol, use mannitol. If they're both readily available, I would just say use hypertonic saline, because you can use it for that rescue therapy as a bolus, and then you can continue that maintenance therapy with hypertonic. Okay. How do we do it? If it's mannitol, it's a gram per kilo over 15 to 20 minutes, again, filtered through filtered tubing. If you have the 23.4% saline, usually it comes in, quote, bullets of like 30 cc's or so. You give 0.5 to 1 cc, or just that whole 30 cc's over 15 to 20 minutes. It's a really effective rescue agent for ICP elevation. You can do the same thing with the 3% saline. The volumes are of course bigger, anywhere from 250 to 500 cc's over 15 to 20 minutes. You can and you should give it through a peripheral if you don't have a central line. Just make sure it's a good peripheral because you want to get the agent in the patient as quickly as possible. This is the concept of the brain code. Many centers have brain code kits, which usually include mannitol and 23.4% saline. Some also have 3% saline and phenylephrine and other things. But usually, in our neuro ICU, it's mannitol and 23.4%. So you would grab, one and give it. If I have the choice and they're both available, I would grab the 23.4%. Okay. Once you've given it, you can either continue giving boluses or start an infusion. I would just say in the ED, it's probably just quicker to just give boluses, and your target is a sodium between 145 and 155. Okay. If you're given maintenance therapy, that's when you should just place a central line. Then there's hyperventilation. I think most people sort of understand the ups and downsides of hyperventilation, but I want to talk real quick about it. Hyperventilation causes an alkalemia, which causes cerebral vasoconstriction and reduces the cerebral blood volume component of the cranium. So the immediate effect is a lowering in the ICP, but of course, the longer you do it and the more magnitude of the alkalemia, the propensity for cerebral ischemia goes up. So it's potentially effective, but also potentially dangerous, especially early on after brain injury. So the bottom line is you should only use hyperventilation as a rescue therapy in someone who has acute ICP elevation and are showing signs of progressing to herniation. And it should be a patient who is on their way to definitive therapy. Neurosurgery already knows about them. They're spinning up the OR, or they're coming down already. That's when you do hyperventilation. Otherwise, just avoid it, especially early on. Okay. The goal with hyperventilation is a PCO2 of 30 to 35, no lower than that, or a pH, more importantly, a pH of 7.45 to 7.5, no higher than 7.5. Okay. So again, Only use it in a special situation where you're rescuing the patient who is on the way to some sort of definitive therapy. Some other considerations, glucose control. So hypoglycemia is bad. So make sure you're monitoring the glucose very, very closely to avoid both hypo and hyperglycemia. You want to get that patient in that, that range of, under 180, 80 to 180. Seizure control. So think about seizure control as treating seizures if they happen, and if they already happened, preventing more from happening. So you're talking either treatment or secondary prevention. Giving anti-epileptics in patients who haven't already seized probably does not have any benefit in this patient population. But if they did already seize, or of course they're already seizing, and in front of you, load them with the anti-epileptic that's easily available to you. I think in most centers, in MedStar, it's Keppra, 16 mg per kg, IV load up to 4 grams. Okay, and then finally, hyperthermia. Again, hypersympathetic state. So hyperthermia can be a manifestation of that, but hyperthermia also does make the brain cook. So you want to make sure that you're getting the temperature within a normal range. Remember, the hyperthermia here is probably because of hypothalamic dysfunction. So Tylenol and other antipyretics probably won't work, or may not work, I should say. So consider other cooling methods if they're hyperthermic. Okay. So that's a quick overview of neurocritical care in the ED. We talked about overall what our goals are: primary brain injury, secondary brain injury. Talked about blood pressure management. Really quick about airway management, how to manage ICP, and some other miscellaneous considerations.